Hi everyone, this is the pre-class PowerPoint on renal function. And of course you know that the discussion of renal function is sort of like the logical extension to the discussion on fluid, electrolyte, and acid-base balance that we had last class period. But not all of the renal disorders that we're going to talk about in class are going to cause fluid, electrolyte, and acid-base imbalances. So as we look at the different disorders in class, we'll talk about which ones do cause those kinds of problems and which ones don't. But like we usually do, let's just start by reviewing a little bit about normal function of the kidneys. Okay, so the kidneys have two main kinds of functions. There are excretory functions and endocrine functions. Okay, let's talk about the excretory functions first. Okay, so you know the kidney's job is to filter the blood, and as it does that, it saves the things that you need, and it gets rid of the things that you don't need. Now, there are some things that you do need, but you don't need large amounts of. So in that particular situation, the kidney will get rid of what you don't need, and it'll keep the amount that you do need. So, when we're talking about things that the kidney gets rid of, what kinds of things are we talking about? Well, of course, we're talking about getting rid of the metabolic wastes, right? So, what are these metabolic wastes? Well, we've got urea, which is the waste products you get when you break down protein. And then there's uric acid, which is the waste product you get when you digest usually meats. Because uric acid is what you get when you break down nucleic acids, and nucleic acids are found in the cells of the animal that you eat. Yeah, I know that sounds gross. Okay. Then there's creatinine, which is the breakdown product of creatine phosphate metabolism. When your skeletal muscles break down creatine phosphate to get energy, the waste product is creatinine. So those are the waste products that the kidneys are primarily excreting in the urine. There's one other thing that I want to mention here that you as nurses are especially interested in. That is the breakdown products of, what do you think? Drugs. Okay, all those medications that you give your patients. The breakdown products need to be excreted from the body, or they're going to build up to toxic levels, and that gets done by the kidneys. All right, so we're excreting the waste. What other kinds of things do the kidneys excrete? Things that you might have too much of. Well, maybe fluid, right? You need some fluid, but sometimes we have more than we need, so the kidney gets rid of extra fluid, and in that way, it also has an effect on your blood pressure. Helps regulate electrolyte balance, because sometimes you have too many of certain electrolytes. We need to get rid of some of those in the urine. And then acid-base as well. Remember when we talked about acid-base balance, we said that the kidneys are one of the main ways to get rid of extra acids or extra bicarb from the body. So the kidneys involved in fluid and electrolyte and acid-base balance. Okay, what about the endocrine functions of the kidneys? Now, strictly speaking, the kidneys are not endocrine glands, but they do have some endocrine functions in that they produce some substances that act like hormones. They travel in the blood and the body fluid, and then they help regulate the function of other tissues that are located far away from the kidneys. What kinds of substances can you think of that the kidney produces that are like hormones? Well, how about renin? Remember we said kidneys were part of the renin, angiotensin, aldosterone system. And just a quick review of how that works. Remember when the kidneys aren't getting good blood flow, they produce renin. Renin catalyzes the formation of angiotensin 1, which gets converted to angiotensin 2 in the lungs. And remember, angiotensin 2 did two things, right? It told the adrenal cortex to make aldosterone, which helps you retain sodium and lose potassium. And of course, if you retain sodium, you retain water. So angiotensin 2 helps regulate blood volume, blood pressure, sodium levels, potassium levels. Okay. But the other thing that angiotensin II does, remember, is it's a very powerful vasoconstrictor. And so the kidneys can affect your blood pressure not just through, fluid balance and so forth, but also through vasoconstriction. Okay, another thing that the kidneys produce that's like a hormone. Do you remember? Erythropoietin, right? And of course you remember what erythropoietin does, right? There's that slide we looked at before, right? When there's hypoxia, the kidneys produce erythropoietin, which tells the bone marrow to make more red cells. Okay, so that's another hormone-like substance that the kidneys produce. Okay, and then the last thing that I'm going to add to the endocrine functions, the kidneys help activate vitamin D. Now, they don't make vitamin D, but they do help the liver to activate it. You see in this slide, it's actually a two-step process to activate vitamin D. You get it from your skin, you get it from food, and the first step in activating vitamin D occurs in the liver. The second step occurs in the kidneys. And you have to have that in order to activate vitamin D. And why do we need to activate vitamin D? Why do we need vitamin D? Because it helps you absorb calcium, right? That's the reason why we add vitamin D to milk, because milk has calcium and we need the vitamin D to help you absorb the calcium. So kidneys are involved in activating vitamin D and regulating calcium balance. Now, here's kind of a little mnemonic to help you remember the 7 functions of the kidney. All of the same 7 functions that we talked about earlier are here. They're just in a different order. So if it helps you to remember, you can think of a wet bed. Okay, so we got the acid-base balance, the water balance, the electrolyte balance, getting rid of waste, they call it toxins here, blood pressure control, through the fluid balance, we've got the erythropoietin, we've got the vitamin D, I guess the blood pressure control stands for the renin part as well. So those are the things that the kidneys do. And of course you can, if you think about these, can you see how if the kidneys fail and they can't do all these things, that's going to affect pretty much every system in your body, right? Okay, we'll talk more about that later when we talk about renal failure. Okay, let's look at the structure of the kidney. You remember that the functional unit of the kidney is the nephron, and this is a little picture of the nephron. And each of your kidneys has more than 1 million of these little nephrons. And I want to point out to you that the nephron has 2 components to it. There is a glomerulus, or a vascular component, where blood is being filtered through the nephron so it can be cleaned. And then we have a tubular component that collects the filtrate that eventually is going to become urine. So we've got the vascular component and the tubular component. Now, if you look at this little diagram, you can see how the nephrons are arranged within the kidney. You remember we divide the kidney into the cortex that goes around the outside and the medulla that's in the middle of the kidney. And the nephrons are all arranged so that the glomeruli part of the nephron are along the outer edges, and then the loopy part that hangs down, those all point towards the medulla of the kidney. All right, let's take a minute to look at the structure of the nephron in a little bit more detail. Remember, we did say that there was a vascular component and a tubular component. We're going to look at the vascular component first. Okay, the vascular component is the part that channels the blood through the kidney in order to be filtered. Now, each kidney is supplied with blood from a renal artery that branches off the aorta. And after the renal artery enters the kidney, it divides several times into smaller and smaller and smaller arteries until finally, when you get down to the level of the nephron, each nephron has its own little set of arterioles. Okay, the first thing that you've got is an afferent arteriole that you see the little black arrow pointing towards the afferent arteriole that receives the blood from the branches of the renal artery and takes it to the glomerulus. Okay, now you see the little black arrow pointing at the glomerular part of the nephron. The glomerulus is like a little specialized tuft of capillaries, and this is where we actually filter the blood. This is where fluid and substances from the blood get pushed out of the blood, and you see how the glomerulus is surrounded by a little capsule. We call that Bowman's capsule, and the fluid that gets pushed out of the glomerulus ends up in Bowman's space inside Bowman's capsule, and then from there it's going to start on its journey through the tubular component of the nephron on its way to becoming urine. But the glomerulus is important because that's where stuff gets pushed out of the blood in order to start on its way to becoming urine. Now, if you count up how much fluid gets pushed out of all of the more than 1 million nephrons that you have in your kidneys per minute, okay, so you add up all the amount of fluid that gets pushed out of all of the glomeruli, and you see how much that is, usually it ends up being about 125 milliliters per minute. And so we call that glomerular filtration rate. How much filtrate gets pushed out of all the glomeruli per minute, that's glomerular filtration rate, or we call it GFR. And it's usually about 125 milliliters per minute. So 125 milliliters of fluid and stuff dissolved in the fluid gets pushed out per minute and starts through the tube on its way towards becoming urine. The glomerulus, the glomerular wall, it has 3 layers. And you can see in this little cross section here that there are 3 layers in that glomerular wall. But the layer that we're interested in is the middle layer. It's the layer that we call the basement membrane. And in this little picture, it's gray. Do you see it? The big black arrow is pointing at a little red arrow that's pointing at the glomerular basement membrane. Okay. Now, the reason why we're interested in the basement membrane is because the basement membrane is the thing that determines what's going to pass through into the urine and what's not. Okay, the size of the spaces between the fibers in that basement membrane is the filter. It's the screen that determines what's too big to go out in the urine and what's not. Now, if you look at the other 2 layers around the basement membrane, you see that there are spaces or openings in it. And so lots of things might get through those 2 layers. But the basement membrane, the spaces between the fibers are much smaller. And so that's the filter that's going to determine what's too big to go out in the urine and what's not. Now, usually things like red blood cells and plasma proteins like albumin, those things are usually too big to go through the basement membrane. So that's why you usually don't find those things in the urine. Once the blood goes through the glomerulus, anything that does not get pushed out into the tubular component then travels on to the efferent arteriole, which you see now the little black arrows pointing at the efferent arteriole. It's on the other side of the glomerulus. Now, here's a different kind of view where you see the afferent arteriole bringing blood into the glomerulus, the efferent arteriole taking it out. The reason why this is important is because the afferent and the efferent arteriole are sort of like the intake and output valve for the glomerulus. And depending on whether the afferent and the efferent arterioles are constricted or dilated, that controls pressure within the glomerulus. And the reason why you care about what the pressure in the glomerulus is because the higher the pressure in the glomerulus, the more stuff is going to get pushed out of the glomerulus into Bowman's space, and the more filtrate you're going to make. Okay, so the higher the pressure inside the glomerulus, the more filtrate you make. Now that leads us to some interesting kinds of situations, because sometimes we want to control how much filtrate we're making. So we may decide to dilate or constrict our afferent and our efferent arterioles to achieve the desired effect. Now in this slide, we see that the afferent arteriole has constricted and the efferent arteriole is dilated. Okay, so if the afferent arteriole is constricted, that means not as much blood comes into the glomerulus, but the efferent arteriole is still dilated, so a lot of blood can leave. So if the afferent arteriole constricts and the efferent arteriole dilates, what happens to pressure in that glomerulus? It's going to drop, right? And if pressure in that glomerulus drops, what happens to GFR, or glomerular filtration rate? Okay, if the pressure in the glomerulus drops, GFR drops as well, so we don't make as much filtrate. On the other hand, what would happen if we dilated our afferent arteriole to let lots of blood in, and we constricted our efferent arteriole? Now what's going to happen to pressure in the glomerulus? Okay, now lots of blood's coming in and not so much is going out, so the pressure in the glomerulus goes up. And what happens to GFR? GFR also goes up. And so now we're making more filtrate than we were. Okay, so you see how the afferent and the efferent arteriole can control how much filtrate gets made. All right, so after we go through the efferent arteriole, now the blood is going to enter what we call the peritubular capillary network. And the peritubular capillary network is just a whole bunch of little capillaries that surround the tubular component of the nephron. And the purpose of those capillaries being there is so that if we decide, oh, we really don't want to get rid of so much sodium or so much potassium or so much water, we can reabsorb some of those things into the capillary network. Or we may decide, oh, we didn't get enough of potassium sent into the filtrate, so I want to get rid of it more. So the peritubular capillary network is there surrounding the tubular component, so we can fine-tune the composition of the filtrate. We can get rid of more stuff than we had originally, or we can reabsorb and save stuff that we originally got rid of. So the peritubular capillary network is there to allow us to change the composition of the fluid or of the filtrate as it moves through the tubular component of the nephron. Okay, from the peritubular capillary network, then the blood enters the renal vein, and from there it goes back to the inferior vena cava, and then back to the general circulation. Okay, so that's the path that the blood travels from when it leaves the aorta to when it comes back to the inferior vena cava and back to the heart. All right, two common problems that can occur with the vascular component of the nephron. Sometimes the renal artery gets occluded, like with a clot, or it gets really narrow, stenosed with atherosclerosis. If that happens, what happens to blood flow to the kidney? Okay, it drops. And if the kidney doesn't get blood to filter, can it make urine? No. Okay, so if there's a problem with the renal artery, worst case scenario, we could be looking at somebody who can't make urine who's going to go into renal failure. Okay, that's one problem that can occur. Another common problem that can occur is sometimes something happens to damage that basement membrane, that middle layer of the glomerular wall. Now remember, we said the basement membrane was the screen that determines what's too big to get into the urine and what's not. If you have a disease like nephrotic syndrome or certain kinds of glomerulonephritis, sometimes that basement membrane gets damaged, and what problem are you now going to expect to see? Right, we're going to start seeing things leak into the urine that don't belong there. Things getting lost in the urine that we can't afford to lose. For example, if we start losing a lot of red blood cells in the urine, what problem are we looking at now? And eventually we're going to develop anemia. What about if we lose antibodies in the urine? Now we're going to have problems with immunity. What if we start losing clotting factors in the urine? Now we're going to have problems with bleeding. Okay, another thing that we sometimes see get lost in the urine is albumin. Okay, usually there's no protein in the urine. If you find protein like albumin in the urine, that usually tells you there's been kidney damage. If you lose albumin in the urine, what problem do you think you're going to see? You're going to see somebody who has a lot of edema, right? Because remember, we said albumin was one of those plasma proteins that gives your blood its osmotic drawing power. It pulls fluid into the blood vessels. And if we lose our albumin in the urine, now we have nothing to hold fluid in the blood vessels. It's all going to start leaking out. We're going to see people with a lot of edema. All right, let's look now at the tubular component of the nephron. Remember, we said that fluid and stuff that's dissolved in the fluid gets pushed out of the glomerulus into Bowman's space in Bowman's capsule, and it starts on its journey through the tubular component of the nephron on its way to becoming urine. And as the filtrate travels through the tubular component, some things get removed and reabsorbed back into the blood. Other things get excreted from the blood into the tubular component. So the composition of the filtrate changes as it travels down the tubular component. We decide to save some stuff. We decide to get rid of more stuff. And so what we're really doing as the filtrate passes through the tubular component of the nephron is we're fine-tuning the urine so that we only get rid of the stuff we really want to get rid of, and we hang on to the stuff that we still want. Okay, now remember, we said that GFR is usually about 125 milliliters per minute. Okay, we make 125 milliliters of filtrate per minute. Of that 125 milliliters of filtrate that gets made per minute, only about 1 milliliter of it actually ends up getting excreted as urine. So only 1 out of the 125 milliliters of filtrate actually gets excreted as urine, which means that the large majority of the stuff that gets pushed out originally eventually gets reabsorbed somewhere along the way. Okay, now that is actually a good thing, right? Because if you actually made 125 milliliters of urine per minute, do you know how often you would have to go to the bathroom? Yeah, you'd have to go like every 2 or 3 minutes, okay? Because your bladder can only hold how much? You know, if you're making 125 milliliters of urine per minute, that's a lot. And you'd have to be drinking so much water all the time too. Okay, so only about 1 of the 125 actually ends up getting excreted as urine. So with that in mind, what would you expect a person's average hourly urine output to be? It should be around 60 milliliters per minute. 60 milliliters per hour, right? Wow. Because if you're making 1 milliliter of urine per minute, then you should be making 60 milliliters in an hour. Okay. Now, if somebody's urine output drops below, say, 30 to 40 milliliters per hour, now we're going to start worrying about their kidney function. Maybe this person's going into acute renal failure. Now, how do you suppose you tell what a person's hourly urine output is? Have you ever noticed that on the front of a lot of Foley catheter bags, there's a little plastic box with little measurement markings on it, right? That box is there for you to measure the hourly urine output without having to empty the Foley bag every hour. Okay, so at the beginning of the hour, you empty whatever urine's in that plastic box into the bag, and you start collecting. And every hour you come back and you see how much urine you collected, you dump it into the bag, and you collect for the next hour. That way you can tell about how much urine a patient is making per hour without having to empty the whole bag every hour. Okay? But the bottom line is that almost everything that we push out at the glomerulus eventually gets reabsorbed somewhere. So let's talk about what gets reabsorbed in what part of the tubular component of the nephron. All right, in the proximal tubule, and you see the little black arrow pointing towards the proximal tubule, almost everything that we consider, quote, nutritionally important gets reabsorbed there in the proximal tubule. So we're talking things like glucose, amino acids, water-soluble vitamins, and those kinds of things. All of that gets reabsorbed there in the proximal tubule. Now, with some substances like glucose, there's a limit to how much can get reabsorbed at any one point in time. And if the amount of glucose in the filtrate is greater than that, then not all of it is going to get reabsorbed, and so we're going to start finding some glucose in the urine. That's what happens to people with diabetes whose blood sugars are not in control. Okay? There's so much glucose in their blood that when the blood gets filtered, a lot of that glucose appears in the filtrate, and while the nephron tries to reabsorb a lot of that glucose, it can only reabsorb so much. And whatever doesn't get reabsorbed appears in the urine. So if you see glucose in the urine, that means that the person's blood glucose levels are pretty high and that the diabetes is not well controlled. Also in the proximal tubule, a whole bunch of electrolytes get reabsorbed there. As a matter of fact, your textbook says somewhere between 65 to 80% of all the electrolytes that are going to get reabsorbed there in the proximal tubule. And, if you reabsorb a lot of electrolytes like sodium and chloride, what's going to follow it? Water, right? Water always follows sodium. So a lot of water gets reabsorbed there in the proximal tubule as well. Now, as you go through the loop of Henle and then to the first part of the distal tubule, you have a lot of different solutes and water leaving and getting, re-entering. And so we have a lot of transition through the loop of Henle and the first part of the distal tubule. By the time you get through that first part of the distal tubule, what you've got is a filtrate that's very, very dilute. As a matter of fact, it's as dilute as it's ever going to get. And from there on out, then we're going to start concentrating. Okay, so through the loop of Henle, the first part of the distal tubule, by the time we get to the end of that part of the tubule, now the filtrate is very dilute. And at that point, we're going to start with the fine tuning. Okay, now the second part of the distal tubule and the beginning part of the collecting tubule, two very important things happen there. First of all, that's where aldosterone does its thing. So you see the black arrow, or the short fat black arrow is pointing at the aldosterone. That's the part of the tubule where aldosterone does its thing. Now, do you remember, where does aldosterone come from? Okay, it comes from the adrenal cortex, right? And do you remember what aldosterone does? Okay, the primary job of aldosterone is to make you retain sodium and lose potassium. Okay, primary job of aldosterone, to make you retain sodium and lose potassium. Of course, if you retain sodium, what else are you going to retain? You can retain water, because water always follows sodium. But the effect on water is a secondary effect. The primary effect of aldosterone is on sodium and potassium. Makes you retain sodium, lose potassium. So depending on how much aldosterone is present from the adrenal cortex, that's going to determine how much sodium and how much potassium you're actually going to excrete in your urine. Okay, so this is the last place where the amount of sodium and the amount of potassium that appears in the urine is going to change. We still will change water, okay, but sodium and potassium, the final word on that is right there at the end of the distal tubule, the beginning of the collecting tubule. Okay, the other thing that happens in that part of the tubule, end of the distal tubule, beginning of the collecting tubule, that's where we regulate acid-base balance. Okay, remember last class period when we talked about acid-base balance, and we're saying the kidney can get rid of acids or it can save acids. It can get rid of bicarb, it can save bicarb. That's where it happens. So do you see where that little black arrow is? It's pointing at the bicarb, and then at the bottom of the tubule there's the hydrogen that stands for acid. Okay, so that's where we're fine-tuning acid-base balance. So that's where the kidney does its thing as far as regulating acid-base balance. From there, in the end of the collecting tubule, one more important thing happens. That is where antidiuretic hormone does its thing. So you see the short, fat, black arrows now pointing at antidiuretic hormone. That works in that last part of the collecting tubule. And antidiuretic hormone, where does it come from? Comes from the posterior pituitary, right? And what does it do? Hey, remember the antidiuretic effect, right? It's going to make you save water, get rid of less water so there is less urine. Okay, so depending on how much antidiuretic hormone is present, that's where we have the final say on how much water we're going to get rid of, how much water we want to save. So that's where we have our final word on how much fluid actually goes out in the urine. Now, maybe you're wondering, why do I even care what happens in which part of the tubule? Okay, the reason why you care is because when you get to pharmacology or you get to MedSurg 1 and you start to talk about diuretics, okay, this is where you're going to find out that some diuretics are more powerful than others. And the thing that determines how powerful they are is where in the tubule these diuretics act. Okay, now, usually what we see is the earlier in the tubule the diuretic acts, the more powerful a diuretic it is. Okay, one of the most powerful kinds of diuretics we have are what we call looped diuretics, like Lasix. Okay, those diuretics work in the loop of Henle to block the reabsorption of water so that more water gets lost in the urine. Okay, if you move further on in the tubule, that's where we have our thiazide diuretics, which are not quite as powerful as the loop diuretics, but sometimes you don't want that powerful a diuretic, right? Or you might cause dehydration. Okay, so we've got the thiazide diuretics that work in the distal tubule. Further on, when you get down to the collecting duct, that's where we see our potassium-sparing diuretics working. So again, the earlier in the tubular component of the nephron that a diuretic acts, the more powerful it is. And so just remember that for when you get to pharmacology. Okay, just quickly, a couple of problems that can affect the tubular component of the nephron. Sometimes the tubular component gets damaged, especially that can occur if there's some kind of ischemia going on. When there's ischemia, then we see what we call acute tubular necrosis. You know, necrosis means what? Like death of tissue, okay? So if we have damage to the tubular component of the nephron because of some death of tissue, of course that's going to change the permeability of the tubular component. And what kind of problem do you expect to happen if we change the permeability of the tube? We're probably going to see fluid, electrolyte, and acid-base imbalances. Okay, the other kind of problem that we sometimes see is we might see some abnormal levels of aldosterone and antidiuretic hormone. Okay, so maybe the nephron is working perfectly fine, but if we have abnormal levels of hormones like aldosterone and antidiuretic hormone, again, we're going to see fluid and electrolyte imbalances. Okay, so those are some common problems that we might see affecting the tubular component of the nephron. All right, one last thing that we want to talk about. We said that blood flow through the glomerulus is regulated by the afferent and the efferent arterioles, whether or not they're constricted or dilated. Okay, but what we didn't say yet is What is it that controls whether the afferent and the efferent arterioles are constricted or dilated? Okay, there are three types of mechanisms that affect that process and that affect what blood flow through the glomerulus is going to be. We have neural control mechanisms, humoral control mechanisms, and what we call autoregulatory mechanisms. Let's just say a few words about each of those. Okay, first of all, the neural control mechanisms. Mostly what we're talking here is the sympathetic nervous system. Okay, the sympathetic nervous system innervates both the afferent and the efferent arterioles and help affect whether they're constricted or dilated. Okay, sometimes they'll constrict, sometimes they'll dilate. It just depends what they're going to do, whatever it takes to keep GFR within a fairly steady, constant rate. Okay, the goal of all of these regulatory mechanisms is to make adjustments to keep GFR at a constant rate. Okay, so whatever it is that the needs of the body are at that moment, depending on whether you've got the fight or flight thing going on or whether you've got fluid deficit going on or whatever, the sympathetic nervous system is going to try and make adjustments to the afferent and the efferent arteriole to keep GFR at a steady rate. Okay, humoral control mechanisms. Humoral refers to your body fluid, right? And what we're talking about here are hormones that are floating around in your body fluid. Some of these hormones make those two arterioles constrict. Some of them make them dilate. I'm not going to burden you with remembering which ones do which at this point. I just want you to be aware that there are hormones that are in your blood that will affect whether the afferent arteriole and the efferent arteriole are constricted or dilated. And again, the goal is to try and maintain GFR at a constant rate. Okay, the last regulatory mechanism we call autoregulation. Auto means what? Auto means self, right? And so we're talking about mechanisms through which the kidney regulates its own blood flow. Okay, there are several autoregulatory mechanisms that the kidney has in place. Probably the primary autoregulatory mechanism is what we call the juxtaglomerular complex or the juxtaglomerular apparatus. And in this little picture, you see those greenish cells. Those are the juxtaglomerular cells. You see they're kind of located near the glomerulus, kind of near the afferent arteriole, kind of near part of the distal tubule, okay? And what these juxtaglomerular cells do is they monitor blood pressure in the afferent arteriole, they monitor the composition of the fluid in the distal tubule, and they use that information to give feedback to the kidney so the kidney can decide how much renin needs to be released. Okay, so the juxtaglomerular cells are monitoring blood pressure in the arterioles, it's monitoring composition of the filtrate, and it's using that feedback to help the kidney decide how much renin to make, which will then affect blood flow to the kidney. Okay, so if you have problems with any of those regulatory mechanisms, that's going to change blood flow to the kidney, which will then change how much urine gets made. It might change the composition of the urine that gets made. And you might start seeing fluid, electrolyte, and acid-base imbalances. You might start seeing blood pressure problems, all of those kinds of things. Okay, there, one last look at the three regulatory mechanisms of the kidney, things that affect renal blood flow. All right, let's look at some common disorders that affect the renal system now, and we will periodically be referring back to this list of the functions of the kidney to see which of those disorders might affect the kidney's ability to do these things and which will not. Let's talk first about urinary tract infection, sometimes abbreviated UTI, because this is probably the most common problem that you're going to run into.
When we use the term UTI, that's a pretty general term. It refers to infection somewhere in the urinary tract. It doesn't really tell you where. If you wanted to specifically state where, you would have to use either cystitis, which means infection of the urinary bladder, or pyelonephritis, which would be kidney infection. Now, you remember that your urinary tract is supposed to be sterile, right? Your GI tract is not sterile, but your urinary tract is supposed to be sterile. Of course, you know that it is open on one end, right? It has to be open in order for the urine to get out of the body. But for the most part, it's sterile. Do keep in mind, though, that it's most sterile on the kidney end of things and least sterile at the urethra end. Now, obviously, since it's open, bacteria can enter and possibly cause infection. And if an infection occurs, it could be fairly simple and uncomplicated, and, the worst thing that could happen would be that you're really uncomfortable, right? But infections can also become very severe or chronic, in which case maybe scar tissue will form and an obstruction could occur, or it could cause some irreversible kidney damage and impaired kidney function. So we always want to catch things early and intervene so we can prevent infections from becoming more severe and causing more serious problems. So what are the predisposing factors to UTI? Well, there's a lot of them, but the first one I want to mention is anything that impairs the urinary tract defenses. Now, I know it sounds weird to think that your urinary tract has defense mechanisms, but it does. Okay, and one of the biggest defense mechanisms is what we call the washout phenomenon. The washout phenomenon is something that happens every time you empty your bladder. Because you remember we said that the urinary tract is open on the urethra end, right? And that organisms might start crawling up. But every time you empty your bladder, that kind of washes out any of those organisms that might have started to enter the urinary tract, and thus prevents it from being able to cause an infection, right? So every time you pee or every time you empty your bladder, the washout phenomenon helps protect you against infection. Now, I put the words void and voiding there because once I used it on a test and people didn't know what I was talking about. Void is just what we call it when you empty your bladder. Okay, it's just the more medical term for it. The bladder also has a special lining that helps to protect it against bacteria or any of the substances that might be in the urine. And there's kind of a mucus layer that lays on top of that lining. And in that mucus, there is secretory IgA. Remember, the antibody that is found in body secretions? And that antibody is there to help defend your bladder against infection. Of course, anything that impairs your immunity is going to increase your risk for infection, right? And then there's urinary retention. Urinary retention just means that we're retaining urine in the bladder. Whether that retention is voluntary because you're just holding it, or whether it's unintentional due to some pathological reason, anytime you have urine just collecting in the bladder, stagnant urine is a great medium for bacterial growth. Okay, so that's going to predispose to infection. Not to mention that if you're holding it, then you lose your washout phenomenon, right? So any organisms that might have started to enter the urinary tract don't get washed away. Now, another reason why urinary retention can increase the risk for infection is if you're not emptying your bladder and urine starts to collect in there, the more full the bladder is, the bladder walls start to get stretched out. And as the bladder walls get stretched, the blood vessels in those walls start to get compressed. And so the bladder wall becomes slightly ischemic. And in that ischemic state, it is more vulnerable to infection. So, anytime you have a patient who is immobile, okay, they're going to have a higher risk for urinary retention and therefore a higher risk for UTI. Because if you've ever tried to pee on a bedpan, especially if you're lying down, it's really hard to empty your bladder completely when you're lying down. So UTI is another one of those complications of immobility that it's your job as a nurse to prevent in your patients. Urinary reflux. What is that? Well, reflux means something's going backwards, right? So urinary reflux means that you have urine going backwards through the urinary tract. Now you remember we said that the urinary tract is most sterile on the kidney end and least sterile on the urethra end. So anytime you have urine going backwards through the urinary tract, you have urine moving from less sterile to more sterile areas, and there is a higher risk for infection. For example, sometimes when people cough or they sneeze, maybe a little bit of urine gets into the urethra and then refluxes back into the bladder. Okay, so you might have that urine carrying organisms from the urethra back into the bladder. Or sometimes in pregnancy, right? As the fetus grows, it may put pressure on the bladder, and that may kind of force some urine from the bladder back up into the ureters. Okay, that would be reflux. Reflux can also occur in patients with a urinary catheter in place because the urine drains out of the bladder into the catheter bag by gravity, right? And so you always have to keep that urine bag below the level of the bladder. If the urine bag gets held above the level of the bladder, especially if there's urine still in that tubing, it can go back into the bladder. And I don't care how good a job you do at trying to keep the contents of that bag sterile. When you empty it, every time you open the nozzle to empty the urine out, that could potentially allow organisms into the bag. And then, if you put that urine back in the bladder, it can carry organisms with it. So it's kind of like when you put in a urinary catheter, you're putting in a little ladder that allows organisms to crawl right into the urinary tract. One of the things that always makes me cringe is, I don't know if you've ever visited a long-term care facility or something where you see these little old people walking down the hallway with their walkers, and they have their urinary catheter bag hooked to the top of their walker, right? That is now raising that bag above the level of the bladder, and urine's going to go backwards into the, back into the body. So now you have reflux and increased risk for infection. So anytime you have urine going backwards, that's not a good thing. While we're on the subject, a urinary catheter can be considered an instrument that we put into the urinary tract. And I don't care how good a job you think you did at sterile technique when you inserted that catheter, there is the possibility that organisms get introduced. Any kind of invasive procedure, whether it's a cystoscopy or whatever, where we insert things into the urinary tract, that is a risk factor for UTI. UTIs associated with urinary catheters are so common that there's a little name for it. We call them CAUTIs, catheter-associated UTIs. And it is one of the big jobs of nurses to prevent CAUTIs in the hospital. Whether a person is male or female also affects their risk for UTI. Who do you think gets more UTIs, men or women? Women, right? Why? Well, first of all, the urethra is a lot shorter in the female, right? So the organisms don't have to crawl so far to get into the bladder. Also, where the urethra is located in the female, it's a lot more susceptible to contamination from vaginal flora, from fecal flora, and, while we're on that subject, anybody who has fecal incontinence is going to also be at higher risk, right? Because you know your GI tract is not sterile. There are bacteria that live in there. And so if there's incontinence of stool and that stool contaminates the urethral area, now we have a big risk for UTI. And then age. Okay, older people are at higher risk, not just because their immunity is not as good as younger people, but also because they have more diseases that cause immobility, right? As you age, you're more likely to get those kinds of chronic diseases that can impair mobility and lead to more stasis and urinary retention. But we also see older people having a higher incidence of certain diseases that do increase the risk for UTI, like older men get that benign prostatic hyperplasia, right, where their prostates enlarge and they kind of pinch the urethra, so it becomes harder to empty the bladder, and so there's more stasis and retention. Older people are also more likely to have diabetes mellitus. And if those people don't control their glucose well, there will be glucose spilling over into the urine. And that glucose in the urine makes the urine an even better medium for bacterial growth, right? So all of those things, the more of those risk factors you have, the higher your risk for getting a UTI. As we mentioned earlier, the two most common types of UTI would be the cystitis, which is the infection of the urinary bladder, and pyelonephritis, which is infection of the kidney. So let's talk about the symptoms of cystitis first. What do you suppose is the most well-known symptom of a bladder infection? It's burning on urination, which we call dysuria, painful urination. And the cause of that burning is probably the irritation that can occur in the urethra when the bladder becomes inflamed. Along with the burning on urination, some people may complain of lower abdominal pain or lower back pain. If you picture about where the bladder is, in the abdominal and back areas down about that level, we might see some discomfort there because of bladder cramping or bladder spasms due to the inflammation. Two other symptoms that occur a lot are frequency and urgency. And those two things are exactly what they sound like, right? People who have bladder infections feel like they have to pee very frequently. And when they have to go, they feel like, I have to go now. Okay, it's like an urgent thing. And the cause of the frequency and the urgency, again, is probably the irritation of the urethra that goes along with the bladder inflammation, because, when the nerve endings in the urethra get irritated and inflamed, that sensation that results makes people feel like they always have to go, and they have to go now. So I've taken care of a lot of little old ladies with bladder infections who, want to be put on the bedpan every 20 minutes. And when you put them on the bedpan, every time they pee like maybe 15, 20 milliliters, because there's really nothing in their bladder. They just feel like they have to empty it because of that irritation. So if that ever happens to you, you ought to take that 15 or 20 milliliters of urine and send it to the lab to culture it, because chances are there's a UTI there. Also with UTI, the urine is usually cloudy. Now, if you look at this picture, the specimen on the right is clear, right? Because you can see the lines on the paper through it. The specimen on the left is cloudy because you notice you can no longer see the lines on the paper that's behind it. The reason the urine is cloudy is because there's white blood cells and bacteria in it. So basically there's like pus in that urine, and that's what's making it cloudy. There's usually a unpleasant smell that goes along with it too, and a lot of times that's one of the tip-offs that you should culture this urine because it smells like there's an infection. Now, there may actually not be much of a fever or an increase in white blood cell count if it's a bladder infection, because the bladder infections tend to be fairly mild. Mostly they just make people uncomfortable. We don't worry about, the function of the kidney or anything. The kidney can still do its own thing. Most of the time in bladder infections, people are just uncomfortable, but a lot of times, other than the bladder, the burning on urination and that kind of thing, they don't really feel that bad. And a lot of times people go to work still and stuff. It's with the kidney infection that people start feeling a lot more sick. Probably because the kidney is a much more major organ and a much more central organ than the bladder is. People with pyelonephritis or kidney infections feel a lot sicker. They're definitely going to be running a fever. It may be, 100, 101, 102. They may have chills, malaise, nausea and vomiting. These people are probably not going to be getting up and going to work, okay, because they feel a lot worse. They're going to have the cloudy urine. It's going to smell really nasty. I mean, even worse than with a bladder infection. As a matter of fact, the smell that goes along with the kidney infection is sort of like a rotten egg kind of smell. It's got that sulfur smell due to all the bacteria that's in the urine. And of course, since the kidneys are located up higher than the bladder is, the pain is also going to be located higher in what we call the flank area, which is sort of like in the mid-back, maybe wrapping a little bit around to the side. So in this picture, if you see where it's kind of colored reddish, that's the flank area. Pain is probably going to be more severe. These people, like I said, are going to feel sicker. Definitely will have the elevated white blood cells and, the higher fever. Interestingly enough, there are some people who have symptoms of both a bladder and a kidney infection, because sometimes people start out with a bladder infection, but the organisms then kind of crawl up the ureters and gain access to the kidneys, and so a lot of times kidney infections actually start as bladder infections and then just spread upwards. So then you might expect to see both types of symptoms. Sometimes, though, there are people who only have kidney infections without having had a bladder infection first. How do you suppose the organisms get into the kidney in those kinds of situations? They get there through the blood, right? Because if you think about it, all the blood in the body circulates through the kidneys in order to get filtered. And so all the organism has to do is somehow get into the blood. And once that happens, it will eventually get carried to the kidneys. Now, even with a kidney infection, the kidney should be able to do all of those functions that we talked about earlier. If the kidney infection is uncomplicated, the kidney should be able to still excrete waste and regulate fluid and that kind of thing. So again, most of the time, these people are just uncomfortable and feeling really nasty, but there's no problem with their kidney function. All right, what do you suppose interventions would be? Okay, logically, antibiotics, right? And we're going to be a little bit more aggressive in treating the kidney infection than with the bladder infection because, if the kidney infection becomes chronic, we have a lot more risk for impairing kidney function than if the infection's in the bladder. So, while we'll use antibiotics for both bladder and kidney infections, for bladder infections, we will probably just do oral antibiotics for a very short course. If it's a kidney infection, we're probably going to start with IV antibiotics and then, switch to oral antibiotics for a couple of weeks after we let the patient go home. So it is going to be a longer course. Just because, we do want to be more aggressive with the kidney infections. We want to make sure we wipe that out before it becomes chronic and does some actual permanent damage to the kidney. Besides antibiotics, what else can you think of that we could do? Okay, the biggest thing other than antibiotics would probably be pushing fluids, right? We want to make use of that washout phenomenon. We want to make sure that we're emptying the bladder, we're not having any retention, so we're pushing the fluids, and we're also going to try and figure out, well, what were the risk factors that predispose this person to that infection? Can we correct those? So if there's any problems with urinary retention or, poor hygiene or whatever, fecal incontinence, that kind of thing, we want to make sure we take care of that so that we can decrease the risk that the UTI will, recur. Next, I want to talk about some obstructive disorders. In other words, disorders that can cause obstruction to the flow of urine through the urinary tract. Now, notice I am not talking about things that obstruct blood flow through the kidneys. Okay, I'm talking about things that obstruct the ability of the urine to get out of the urinary tract once it's made. Okay, now, the problems that urinary obstruction can cause are going to depend on how obstructed the urinary tract actually is. Is it, a partial obstruction or a complete obstruction? And also on how long the obstruction lasts. Okay, if it's not too long and the obstruction is not complete, then probably what we're going to see is maybe the patient has some pain. There might be some urinary stasis or urinary retention that can predispose to infection, but probably nothing worse than that. If we're talking a more complete obstruction of the urinary tract, this is a much more serious thing. In the picture on the right, you notice that there's a kidney stone that got stuck in a ureter, and that's a pretty complete obstruction. Urine is backing up behind that stone and can't get out. Okay, so notice what's happening. The urine is collecting in the ureter, and the ureter is getting very distended. That's what we call hydroureter, where there's like a whole bunch of extra fluid in that ureter. Well, you know that the ureter can really only distend so far, right? And if we're still making urine and we can't let it through, okay, now instead of just the ureter getting distended, the kidney itself is going to start getting distended as the urine backs up into the kidneys. The kidneys get distended, and now you've got what we see in the left picture, hydronephrosis, where it's not just the ureter that's distended. Now the kidney is distended. But the kidney can also only stretch so big, and if the urine continues to collect, what's going to happen is pressure builds up in that kidney, and as the pressure increases, it's going to compress the blood vessels in the kidney, and the kidney is going to become ischemic. Okay, and at that point where the kidney's not getting adequate blood flow, we might see some permanent kidney damage done, right? Because kidneys aren't getting enough blood, not getting enough oxygen, kidney tissue is going to become damaged. We might actually be looking at a renal failure here if we don't change that picture. So the consequences of obstruction in the urinary tract, again, depends on how complete and how long-term that obstruction is. So kidney stones are probably the most common cause of obstruction in the urinary tract, but here's another common cause. Benign prostatic hyperplasia, right? Remember we said that as the prostate enlarges, it can start to pinch the urethra, and if the prostate gets big enough, it can pretty completely shut that down, and now the urine can't get out. Sometimes there's scar tissue that can form in a ureter Whether that scar tissue is because of chronic inflammation or recurrent UTIs, regardless of how that scar tissue forms, it can potentially obstruct the outflow of urine from the urinary tract. So I wanted to pick one example of an obstructive disorder to look at in a little bit more detail. And so the one I picked was kidney stones, because I think that is the one that is most familiar to people. There are a lot of names for kidney stones. We might call them urinary calculi, renal calculi, nephrolithiasis, urolithiasis. Anything with the root calc or lith, could possibly be related. Calc meaning calcium, which is the most common thing that kidney stones are made out of. Lith, any word that has lith in it, there's some kind of stone involved there. Okay, and I tried to give you all of the different terms that we use for kidney stones in your vocabulary list. And again, you never know which of those terms I'm going to choose to put on the test. So I would learn all of them if I were you. Let's talk about some things that can encourage the development of kidney stones, like having urine that's super saturated with something that stones are frequently made out of. All this means is there's a high concentration of that substance in the urine, making it more likely that that substance will precipitate out and form into a stone. Probably the thing that stones are most commonly made out of is calcium. So if you have a high concentration of calcium in the urine, it's more likely that calcium will form into a stone. And as far as how your urine gets super saturated with that substance, it could either be that person has some kind of disease that increases the amount of that substance in the body. Like in the case of calcium, maybe they have a bone disease, or maybe they have a parathyroid disease. Your bones have a lot of calcium in it, and if calcium is leaving the bones, there might be a lot of calcium in the blood, and therefore a lot of calcium ends up in the urine. If there's a problem with the parathyroids, the parathyroids regulate calcium balance in the body. So it could be something like that increases the concentration of that substance in the urine. Or it could be something as easy as just getting dehydrated, right? Because if you get dehydrated, there might be the usual amount of calcium in your urine, but there's so much less water in it now that urine is very concentrated. It's super saturated with that calcium. And so now a stone is a lot more likely to form. I have to say in the last 5 years or so, I personally know about 5 or 6 people who had kidney stones, and none of them had any other disorder that caused it. I think they all just got really dehydrated for one reason or another, and then they formed a stone. Interestingly enough, your kidney cells do make certain substances that are designed to prevent stone formation. And if for some reason your kidney cells aren't making those inhibitors, maybe because of a genetic disorder or maybe because of damage to those kidney cells at some later point in time, if they're not making those inhibiting substances, now you have somebody who's at higher risk to form a kidney stone. There are also certain trigger substances that could appear in the urine that could get the stone formation process going. I'm talking about things that are normally not found in the urine, things like blood cells or pus or dead tissue. If these things are present, they could serve as a nucleus, and the calcium or whatever other substances in the urine might start crystallizing around these things and start forming a stone. So these are things that could trigger the stone formation process. If you have those substances in your urine, the likelihood of a stone forming goes up a lot. One of the things that can serve as a trigger is anything that's a foreign substance, like a urinary catheter. Here's a picture of a urinary catheter that did serve as a trigger, and notice how the calcium crystallized around it. I took care of a patient in a similar situation. He happened to be quadriplegic, and so he was on bed rest, of course. He didn't have any weight bearing on his bones, which is what you need in order to keep them mineralized. So the calcium was leaving his bones, entering his blood. That was too much calcium for the blood, so the kidneys filtered the calcium into the urine. So his urine was super saturated with calcium. And, when we admitted him, he had a big pressure sore on his backside. And so, it had gotten infected, so we were treating him with antibiotics. But when I did the nursing history on him when I admitted him, I discovered that he had this urinary catheter that had been in there for like 9 months. And so we were like, we should probably change that. And so I deflated the balloon and I started to pull the catheter out, and the catheter looked like that when it came out, and it had kind of scraped his urethra on the way out, and so there was some blood that came with it, and I felt really bad. But the only silver lining to that cloud was he was quadriplegic, so he didn't feel that, right? 'Cause otherwise I'm sure he would have been screaming, right? But this is an example of a foreign substance that served as a trigger that started the stone formation process, and the calcium just crystallized around it. If there's urinary stasis present, stones are a lot more likely to form because, if you have urine that's super saturated with something, that something is probably going to precipitate out of the urine much more easily if the urine is stagnant instead of, moving on through the urinary tract. And then the pH of the urine can affect whether the stones are going to form or not. Depending on what substance the urine is supersaturated with, some substances precipitate out more easily in acid urine and some more easily in alkaline urine. So again, depending on what that substance is, the pH of the urine can also determine how easily a stone is going to form. As you've probably gathered by now, there are several different kinds of kidney stones, with calcium being by far the most common. There are calcium oxalate and calcium phosphate stones, although I believe the calcium oxalate stones are the more common. But calcium-based stones are usually related to either bone disease or parathyroid disease or immobility, right? Because remember that you need to do weight bearing in order to keep your bones mineralized, and people who are immobile are not doing the weight bearing, and so the calcium tends to leave their bones. Or, again, remember, it could just be people getting dehydrated, right? The next most common kind of stone is struvite, and in case you're like me and like, what in the world is struvite? Okay, struvite is a compound made up of magnesium, ammonium, and phosphate. And then there are a few uric acid stones, and then cysteine stones are the least common. Now, why do you suppose we as nurses even care what the stone is made out of? We care mostly because knowing what that stone is made out of helps us to know how to prevent that patient from forming more stones in the future. If we know what the stone is made out of, we can teach the patient to change their diet, or maybe put them on certain medications that will keep that substance out of their urine. We might be able to change the pH of the urine so that that substance is less likely to precipitate out. So when we have kidney stone patients, we always tell them to strain their urine so that they can catch a stone if they should be able to pass one. We can send that stone to the lab and they can analyze it and tell us what it was made out of. So patients always get this little strainer and they're supposed to strain their urine. This is also why we want to know those predisposing factors that we talked about. Do they have supersaturated urine? Do they have trigger substances in their urine? We want to know those kinds of things so that we can, again, implement education or interventions to help that patient prevent recurrences. And I'm sure you know that the primary symptom of kidney stones is pain, right? Excruciating pain. The pain in kidney stones comes from two things. Okay, first of all, when the kidney stone gets stuck in the ureter, if urine is collecting behind it and the ureter gets distended, that distension creates a lot of pain. And from my reading, I understand that the degree of pain is not necessarily due to how distended the ureter becomes, but to how quickly it becomes distended. So if it becomes distended very quickly and stretches really fast, that is going to be a lot more painful. Okay, the other thing that triggers the pain is when the stone gets stuck in the ureter like that. The ureter generates these peristaltic waves to try and move the stone through. And those peristaltic waves create a crampy, spasmodic type of pain that we call renal colic. So I don't know if you're familiar with the kind of colic that babies have. That's usually due to spasms and cramping in their intestines. So when we have renal colic, now the spasms and the cramping are not in the intestines, they're in the ureters, okay? But it still generates this kind of really intense type of pain. The pain is usually severe enough that it triggers the sympathetic fight or flight. So there's the pale, cool, clammy skin and the nausea and vomiting that frequently go along with that. The location of the pain is usually the flank area. So you now know where the flank is, right? So it's usually severe flank pain, can radiate around to the upper outer quadrant of the abdomen and then down towards the groin. Okay, so if you picture the pathway that the ureters travel from the kidneys to the bladder, that's sort of the direction that the pain is going to radiate. Now, the renal colic type of pain is usually what occurs if the kidney stone gets stuck in a ureter. Every now and then, the stones actually don't get stuck in a ureter. They're actually in the renal calyces. So in this picture, you can actually see there are two stones in the renal calyces. If the stones are there, they're probably not going to generate the colicky type of pain. In this situation, the pain is probably going to be more of a dull, deep ache in the flank. And, sometimes it's milder, sometimes it's more severe, but because you're not getting those peristaltic waves and you're not getting the stretching of the ureters, it's not going to be that colicky type of pain. Sometimes we also see some hematuria or blood in the urine because kidney stones are not like little smooth pebbles. They're usually rough on the outside, more like coral, or maybe they even have some spikes on them. So it's understandable how if those stones are passing through the ureters, they can scrape the lining of the ureters and there might be some blood in the urine. I have some pictures that I want to show you of kidney stones, just so you can get a better idea of how they can cause bleeding. This is actually kind of a big one. They're not all this big. But even the tiny ones can cause a lot of pain. Because look at that spikes and sharp edges on them. This one especially makes me cringe. So even though there might be stones that look really, really tiny like this one, if you look at them with a magnifying glass and they have all these spikes on them, you can understand why it, can cause trauma and bleeding, and also why there's a lot of pain involved. Now, even with a kidney stone present, the kidney should still be able to do all of those functions that we talked about at the beginning of this recording. The only time the kidney might not be able to do those functions is if we get to the point of hydronephrosis, okay, to where there's so much back pressure on the kidney that the kidney is becoming ischemic and there is potential for kidney damage. At that point, we might start seeing signs of renal dysfunction. So we always hope to be able to get rid of the stone, relieve the obstruction before we get to that point, so that we can avoid any loss of kidney function. As far as interventions, of course, one of the big priorities is pain relief, right? And the pain in kidney stones is intense enough that we often bring out the opioid narcotics like morphine, okay? But it is also very common to give Toradol or ketorolac instead. Toradol is an injectable NSAID, so it is not a narcotic. It doesn't have that addictive property, but it really is only for short-term use because it does carry with it an increased risk of clots forming, things like heart attacks, strokes, that kind of thing. And, because it's an NSAID, there's also a risk for GI bleed as well. So it's really only for short-term use. If we go with the Toradol, very frequently it's given IM or even IV. And, coming from my husband who's actually had some kidney stones, he says Toradol works great. The next order of business would be to try and get rid of the stone, right? And how we choose to do it will probably depend on how big the stone is. If it's not very big, we would try the push fluids and ambulate method, right? The thought being, we get them to drink a lot of water so they make a lot of urine, and we have them walk around, so hopefully that will flush the stone out. The patient can pass it, we can get it and send it to the lab, right? If the stones are too big and we don't think the patient is going to be able to pass it on their own, we do have several choices, one of which is extracorporeal shockwave lithotripsy, okay, which sounds big and complicated, but all it is, it's generating ultrasound shock waves that we focus on the stone in an attempt to shatter the stone into small enough pieces that then the patient can do the push fluids and ambulate method and be able to pass them. So extracorporeal just means, we're generating the shock wave outside the body. This is a non-invasive kind of thing. Here you can see what the lithotripter looks like. You see the little gel-filled pad that's pushed against the patient's flank, and you can see they're kind of visualizing where the stone is on the fluoroscopy so they can try and focus the shock waves on the stone. And here you see a close-up of the gel-filled pad that they're going to use to transmit the shock waves through to the stone. Of course, it can cause some bruising, but it is non-invasive. And, the other downside of this is that the patient will still have to pass the stone fragments. And so there will still be some discomfort and some possibly bleeding as the stone is passed. We also have the option to use a ureteroscope, which, has a little camera on the end. So as we advance it up the ureter, we can actually kind of see what's going on. And through the scope, there's usually also a place where we can insert instruments like little baskets to try and, snag a stone and remove it. Or we might use that ureteroscope to insert a laser and laser the stone, and it turns into like a little sludge kind of thing that then the patient should be able to pass. And if we do that kind of thing, we will sometimes leave a double J stent in. You see one little curlicue end is in the kidney, the other curlicue end is in the bladder. The curlicue is to hold the stent in place. The purpose of the stent is to try and make sure that the urine can drain, because sometimes because of maybe trauma from the stone, there will be some swelling in that ureter, and that swelling can cause some obstruction. And we don't want that obstruction. We want the urine to be able to drain freely so there's no back pressure in that kidney. So we might leave the stent in for a few weeks, and then when it's not needed anymore, we can just go in with the little scope and pull the stent out. Now, if there are a whole bunch of stones or they're pretty big, we might just go ahead and do a percutaneous nephroscopic removal. So percutaneous means through the skin, so we would just kind of use this nephroscope and, insert it into the kidney and remove the stone. And it looks pretty, it doesn't look so bad in this picture. But when you see what it looks like in real life, this is not something that just anybody would want to have done, right? Now, if the stone is really huge, we would just have to cut the person open and surgically remove it. And in case you're wondering how big a kidney stone can get, sometimes people form what we call staghorn calculi, like this. And you can kind of see why they call it that, right? Because the stone is taking up the renal pelvis and extending into the renal calyces, so it looks kind of like the antlers on a deer, right? So they call it staghorn. And if you go on the Guinness Book of World Records website, okay, they actually just updated that. The largest stone officially documented is now a little more than 5 1/4 inches at its widest point. Okay, and it weighed 1 3/4 pounds. Okay, that's huge. That's one that you would never be able to laser or shatter and expect the patient to be able to pass all the pieces. And here is a picture of what a staghorn calculus might look like in real life. Okay, so after the stone is removed, of course, we want to know what kind of stone it is, so we can talk about possible changes in the person's diet or changes in the pH of their urine to try and prevent recurrences. We would want to identify what were the predisposing factors and try and eliminate those or correct those if we can. Of course, people need to stay hydrated and things like that. All right, the last kidney problem we're going to talk about is renal failure. And when we use the term renal failure, we're referring to a state in which the kidneys are not able to adequately remove the metabolic waste from the blood and not able to adequately regulate fluid, electrolyte, and acid-base balance. Okay, now if you think about it, if the kidneys can't remove waste and they can't regulate fluid, electrolyte, and acid-base balance, that's pretty much going to affect every system in the body, right? Now, renal failure can be either acute or chronic. If it's acute, we call it acute kidney injury, or AKI. And if it's chronic, we call it chronic kidney disease, or CKD. And you know the difference between acute and chronic by now, right? Acute are things that come on more suddenly, they're more severe from the beginning, but you can get rid of them. Chronic are problems that come on much more slowly and gradually. They're not as severe, at least in the beginning, but once you have it, you pretty much have it for the rest of your life, okay? All those things are true for acute versus chronic renal failure. Let's talk about acute first, okay? Now we can actually divide acute kidney injury into 3 types. We have pre-renal, intrarenal, and post-renal. Now, I know a lot of people, when they hear those terms, they immediately correlate it with time. Pre, post, that sounds like it's time-related, right? But it's not in this case. Okay, instead of being time-related, it's location-related. And what I mean by location-related is the classification is determined by where the problem starts. Does it start before we even get to the kidney? Is the problem with the kidney itself? Or is the problem after the kidney? The urine's already made, the problem's somewhere else in the urinary tract. Okay, so this slide here is intended to remind you that pre, intra, and post are not time related. They are location related. Okay, so let's go back to our other slide and see what the details are. So with pre-renal failure, okay, the problem is before you even get to the kidney. So pre is before, right? So the problem is before you even get to the kidney. And the only thing that really happens as far as making urine, that is before you even get to the kidney, is that the blood flows to the kidney, right? The blood goes to the kidney in order to be filtered. So you see that little number 1 in this diagram, indicating the renal artery. So pre-renal failure is caused by problems with blood flow to the kidney. Because after all, if the kidney doesn't get any blood to filter, can it make urine? No. If the kidney doesn't get blood to filter, it can't make urine, it's going to fail. Okay, so let's think about things that can interfere with blood flow to the kidney. Maybe the person has a really big clot in the renal artery. Okay, blood's not going to get to the kidney can't make urine. Okay, or maybe the person got in a big car accident and was bleeding heavily and lost a ton of blood, and there's just not that much blood in this person's body. So not that much blood goes to the kidney doesn't have blood to filter, it fails. Okay, or maybe you have somebody with severe heart failure. And you remember the problem in heart failure was poor cardiac output, right? If the cardiac output drops really low, then there's not going to be very much blood going to the kidney. The kidney doesn't have blood to filter. It can't make urine, and it fails. Does that make sense? What about intrarenal failure? Intra means inside, right? So the location that we're talking about in intrarenal failure is inside the kidney. There's something that's actually damaged the kidney itself, and that's why the kidney is failing. Okay? So whether it's damage to the tubular component of the nephron or to the vascular component of the nephron or both, it's the problem within the kidney that is causing the kidney failure, and so that's intrarenal failure. Okay, so what kinds of things can damage the kidney? Well, maybe it's an autoimmune disease, right? The immune system's attacking its own kidney cells. Or maybe the kidney was exposed to some kind of nephrotoxic agent. Okay, so what does nephrotoxic mean? Nephro means kidney. Toxic is like poisonous, right? So a nephrotoxic agent would be a substance that is basically poisoning the kidney or damaging the kidney. People get exposed to nephrotoxic substances maybe in their workplace. They work with different chemicals. Sometimes we give nephrotoxic drugs. There are certain kinds of antibiotics that are considered nephrotoxic. That radiopaque contrast that we use for certain kinds of X-ray tests, that is considered nephrotoxic. Okay, so maybe they were exposed to some kind of drug or chemical that damaged the kidney. Or maybe the kidney became ischemic and that damaged it. If there's not enough blood and not enough oxygen going to the kidney, then the kidney can become damaged. Okay, now if you're thinking, you might be going, wait a minute, I thought problems with blood flow to the kidney were pre-renal, not intrarenal. Okay, that's a good point. There is a dividing line. Okay, if there's poor blood flow to the kidney, but no cells have been damaged yet, that is pre-renal. Okay, if there's poor blood flow to the kidney to the point where the kidney gets damaged, now it's intrarenal, right? The kidney itself is damaged. And that might seem like a fine line between the two. But if you were the patient, which would you rather have? You'd rather have the pre-renal failure, right? Why? Because no cells have been damaged yet, right? And so a pre-renal failure would be easier to recover from than an intrarenal failure, because in intrarenal failure, there's actual damage to the kidney. An example of a problem that would be considered intrarenal failure would be acute tubular necrosis, right? There's necrosis of the tubular component of the nephron, and so that is intrarenal. And then there's post-renal failure. Post means after, right? So the problem in post-renal failure is not before the kidney or with the kidney itself, but it's a problem somewhere after the kidney. So in other words, the kidney's already made the urine. The problem in post-renal failure is that the urine can't get out of the urinary tract. There's an obstruction to the outflow of urine, and so now the urine's backing up. There's that back pressure on the kidney. That back pressure compresses the vessels in the kidney, so the kidney becomes ischemic. Okay, and now because the kidney's ischemic, now it's going to fail. Okay, so eventually the kidney does fail, but the initial problem was not with the kidney itself. The initial problem, the cause of the post-renal failure, is after the kidney with that obstruction. Okay, so remember we talked about how the stone got stuck in the ureter and the back pressure could cause the kidney to fail? That's a great example of a post-renal type of renal failure. So again, this slide is just to remind you that when we say pre, intra, and post, we are not talking about time. We're not talking before the kidney failed or after the kidney failed. We're talking about where is the cause of the failure located? Is the cause located before you even get to the kidney? Is it located in the kidney, or is it located after the kidney's already made the urine? Does that make sense? All right. So when you get to your clinical courses and you have to do care maps, you don't want to stop by just saying, oh, my patient has acute kidney injury. You know, your instructors are going to want to know, why did this patient's kidney fail? Is it a pre-renal, intrarenal, or post-renal kind of situation? Now, remember we said that acute problems usually can be reversed, right? You don't have to live with it forever. However, if we don't catch acute kidney injury early and intervene, it is possible for the damage to become more permanent and for it to progress into a chronic kidney disease. Chronic kidney disease, though, is usually more a result of chronic kinds of conditions, problems that develop gradually over a long period of time. So most cases of chronic kidney disease are due to systemic diseases like diabetes or lupus, or to long-term uncontrolled hypertension, to chronic kidney infections. You know, so they usually aren't things that come on very suddenly, but things that develop gradually over many years. Now, in your study guide, I included 2 different ways that chronic kidney disease can be staged. In other words, these are the terms that you will see in patients' charts to indicate how far along the patient's chronic kidney disease has progressed. Okay, the first set is the older terminology. The second set is the newer terminology that you'll probably be seeing more now. There are still a few older clinicians that might be using the older terminology, so I stuck that in there for you. But if you look at the 2 sets of definitions, they're basically the same. They're just using different terminology. You know, so they're all basically progressing from a very early stage where GFR is starting to drop, but there aren't any symptoms yet, and then progressing to end stage or kidney failure to where the patient needs to be on dialysis, or they need to have a transplant, or they're going to die. Okay, so I'm not going to ask you to learn all of these stages or memorize any of these numbers or anything like that. I just want you to have this as a reference for when you go to the hospital and you start reading patients' charts. And also, you know, to just get an idea that the progression progression in chronic kidney disease is pretty gradual. And as the disease gets worse, we're going to see the GFR dropping further and further, and we're going to start seeing more and more symptoms. In other words, remember that list of functions that we said that the kidney does. Okay, as chronic kidney disease progresses, the kidney is going to get less and less capable of doing all of those functions. So these are the two symptoms that are probably going to show up first in your chronic kidney disease patients: isocinuria and azotemia. Okay, now isocinuria just means the patient is putting out large amounts of very dilute urine. Now that seems kind of weird, doesn't it? Because usually when people think of someone kidneys failing, they usually think about somebody who is not able to make urine, right? But isocinuria is the first sign that the kidney is losing function, because while it's still making urine, it's losing the ability to appropriately concentrate it. Okay, so we're putting out large amounts of very dilute urine. As a matter of fact, we're putting out urine that's basically the same as plasma, right? It's the same as blood without all the blood cells and stuff in it. So that really does indicate the kidney is losing its ability to appropriately filter and concentrate, because it's just excreting, basically the liquid part of the blood. Okay, so this is the first sign that the kidney is starting to lose its capabilities. Azotemia means that we're having a high level of nitrogenous waste products in the blood. And one of the jobs of the kidney is to get rid of those nitrogenous wastes, right? So if we're starting to see an increase in the level of those waste products in the blood, that does tell you that the kidney is losing its ability to appropriately excrete waste. Now, at this point, we're not seeing any symptoms from the higher level of waste products in the blood yet. Okay, so when we draw blood, we see there's higher levels of waste in the blood, but that is not yet causing problems or symptoms. As the chronic kidney disease progresses or gets worse, now we're going to start seeing uremia instead of azotemia. Uremia means we have a high level of waste products in the blood, and now we're starting to see some symptoms, okay? And then we're going to start seeing the fluid electrolyte and acid-base imbalances. Okay, so once we see uremia and fluid electrolyte and acid-base imbalances, now we know that we're much farther along in the progression of chronic kidney disease. Now, the assessment findings are actually pretty similar between acute and chronic renal failure. Mostly what we're seeing is the inability of the kidney to carry out all of these functions that we talked about earlier. So what we're going to do is we're going to go through this list of functions and see what's going to happen when the kidney can't do these things anymore. And after we've gone through all of them, then I'll tell you which ones are more likely to appear in chronic kidney disease than an acute kidney injury. But keep in mind, the majority of these symptoms are going to show up in both types of conditions. So let's talk about the excretory functions first. We know that one of the big jobs of the kidney is to excrete metabolic wastes. And so if the kidneys fail, we're going to start seeing uremia, right? Remember, uremia was a high level of those nitrogenous waste products in the blood, and they are now starting to cause problems. So, what are these nitrogenous waste products that the kidney is supposed to be excreting in the urine? Remember earlier we talked about urea and creatinine being two of the primary waste products that are supposed to be excreted. So the two most common blood tests we run to check kidney function are BUN and creatinine. Okay, now BUN stands for blood urea nitrogen. So we're measuring the level of urea in the blood. And I kind of like that we call it BUN, because that reminds you that we're looking at the level of urea in the blood. One quarter back when I still taught a lab group, a student came to me showing me some of the lab reports and said that they were really worried because they showed me how much urea was in this one sample. And I happened to notice that it was actually a urine sample instead of a blood sample. And it's like, well, there's actually supposed to be a lot of urea in the urine, right? It would be if there's a lot of urea in the blood that we get worried about. Okay, so BUN is the amount of urea in the blood, and if the BUN goes up, now we are kind of concerned about the kidney. Okay, so you remember that urea is what you get when you break down protein. Creatinine is what you get when you break down creatine phosphate, which is a high energy compound that your skeletal muscles use to, get ATP in order to function. Okay, so those are two waste products that your kidneys are supposed to get rid of in the urine. If the levels of those go up, we know the kidney is not doing a good job of getting rid of those waste products. Now, we usually run both BUN and creatinine, but one of those two tests is more definitive to kidney function. The one that's more definitive is creatinine, and here's why. There are actually a lot of things that can affect your BUN, but really the only thing that makes your creatinine go up is when the kidney function is poor. Okay, so if you think about what urea is, okay, urea is what you get when you break down protein. Okay, that makes it easier to understand why there are a lot of things that can make your BUN go up. For example, if you have somebody on a high protein diet, you kind of expect that there's going to be more urea in their blood, right? Because if we're breaking down more protein in the diet, okay, there's going to be more urea. Okay, what if you have somebody who is starving, who's not eating anything? Okay, their BUN might also go up, because if you think about it, if you have somebody who's not eating and they're starving, what is their body going to be using for fuel? It's going to be breaking down the body protein, right? It's going to be breaking down its skeletal muscles, and your skeletal muscles are made of protein, and so you're going to get urea. Okay, so that's another thing that might make your BUN go up. If you have somebody who has a GI bleed, right, there's red blood cells in their stomach. Okay, their stomach is going to start digesting those red blood cells, right? And what do you think is in those red blood cells? Protein, right? So can you see how there's a whole bunch of things that can affect your BUN besides just poor kidney function? On the other hand, if you think about creatinine, that's what you get when your skeletal muscles break down the high energy compound to get ATP, right? The only other thing that could probably change the creatinine besides the kidney not being able to get rid of it is if you had a sudden change in your muscle mass, right? If you suddenly make more muscle or you suddenly have way less muscle, then you might see the levels of creatinine change. But, you're not going to start making a whole bunch of extra skeletal muscle overnight, right? It's going to take a lot longer for creatinine to change because of changes in your skeletal muscle mass. So for that reason, creatinine is usually considered a better reflection of kidney function because there aren't quite as many things that can change your creatinine as there are things that can affect your BUN. Does that make sense? All right, so now we have a high level of these nitrogenous waste products in the blood, and the level is high enough to start causing symptoms, right? So now we have uremia, not just azotemia. Okay, so what kinds of problems does having all that waste products in the blood cause? Well, one of the things it causes is uremic encephalopathy. So what is encephalopathy? Encephalo refers to brain. Apathy refers to some sort of pathology. So when the levels of waste products in the blood get really high and we have uremia, the brain doesn't function that well. It can't work with all of that waste products floating around. Okay, so we're going to see varying degrees of lethargy. There might be some impairment in the memory and the attention span. In the later stages of the disease, as the levels of waste products get really high, we start seeing people who become confused or maybe even go into a coma. Okay, now, one quarter we were talking about uremic encephalopathy in class, and a student said, I took care of a patient with renal failure last week, and they were alert and oriented. They were not confused. They were, in end-stage renal disease. I don't understand why they didn't have this encephalopathy. So then I said, well, is this patient on dialysis? And they said, yes. Well, there you go, okay, because the dialysis removes the waste products, and that's why there was no encephalopathy. Does that make sense? Now, your platelets and clotting factors also do not work well floating around in all that waste product. And so we're going to see problems with bleeding, right? Maybe people bruise easily. Maybe they have GI bleed, and so you need to check the stool for blood. Maybe they have epistaxis. Do you remember what epistaxis is? Nosebleeds, right? And the white blood cells also don't function very well. And so we're going to see poor immunity, right? Increased risk for infection. A high level of waste products in the blood also interferes with the function of the peripheral nerves. So we have people with peripheral neuropathy. Right, so peripheral neuropathy can cause, the tingling, pins and needles kinds of feelings. It could even cause things like restless leg syndrome. Have you heard of restless leg syndrome? It causes these like itchy, creeping, prickly sensations in the legs that seem more intense when they're resting. So they move their legs around a whole lot. I remember going to the hospital to visit a friend who had restless leg syndrome, and it looked like she was riding a bicycle underneath her covers because her legs were just never still. So this is what can happen if there's peripheral neuropathy and those peripheral nerves are not functioning correctly. They might also complain of these burning sensations in the bottoms of their feet and things like that. They might also complain of pruritus. Do you remember what that is? Pruritus is itching, right? And patients with renal failure might complain of itching if they have uremic frost. Uremic frost is when people have like little phosphate and urea crystals precipitating out on the skin. Because what happens is, because the urea and the phosphate are not being excreted in the urine, because the kidney is not making urine, the body looks for other ways to get rid of them. And one of the ways it tries to get rid of the urea and the phosphate is through the sweat. And so these things crystallize out on the skin when the sweat dries, and it looks like this white powdery substance. They call it uremic frost because it sort of looks like the frost that you see outside on the blades of grass in the winter when it gets cold. I think it's a little easier to see in this picture, the little white powdery stuff. Also, because of all the waste products in the blood, people are going to not feel good. They're going to either have anorexia or maybe even nausea and vomiting. They're going to feel very tired and weak. And the other thing that you as nurses need to keep in mind is, remember, part of the job of the kidneys is to get rid of the breakdown products of the medications that we give. Right? And so if the kidneys fail, we might be looking at potential for drug toxicities, right? Because maybe the breakdown products of these drugs can't get out of the body, so the levels are going to build up in the body, and we might see some signs of overdose. So we might need to think about decreasing doses or maybe changing to other drugs that are not excreted from the body through the urine. So another job of the kidney is to regulate fluid balance, right? And so if the kidneys fail, we expect to see some fluid imbalances. Now, if the kidney's not making urine, you would expect that there would be some fluid overload, right? But keep in mind that there also might be times where the patients actually get dehydrated, right? Remember, we talked about the early stages of chronic kidney disease where the patient has isostenuria, right? They're putting out large amounts of very dilute urine because even though the kidney is making urine, it can't concentrate it correctly. And so people with isostenuria might actually have dehydration instead of fluid overload. There is actually even a stage in acute kidney injury where there might be something like isostenuria. Only in acute kidney injury, it would be as the kidney starts to recover function, right? In acute kidney injury, it loses the ability to make urine fairly quickly. It's acute, right? But you can get rid of it, and so as the kidney starts to recover, it starts to be able to make urine again, but can't appropriately concentrate it yet. So they do have a type of isostenuria, even in acute kidney injury, which could lead to dehydration. But, of course, the more common problem that you're going to see in renal failure is the fluid overload. So if the kidney's not making urine, then we're going to have a very small urine output. We call that oliguria. Olig referring to few or scanty, just a little bit, right? So we just have a little bit of urine output. And that, of course, is going to lead to fluid overload. Now, how do you know if your patient has fluid overload? What's going to happen to their blood pressure? It's going to go up. What's going to happen to their weight? It's going to go up. Okay, if they have too much fluid on board, they might have edema, right? It could be peripheral edema or dependent edema where we're checking their ankles, or it could be pulmonary edema, right? How do we know if our patients have pulmonary edema? We're going to hear crackles, right? All right. Going back to our list, you remember that the kidneys are also supposed to regulate electrolyte balance, right? And so if the kidneys fail, we expect to see some electrolyte imbalances. The three electrolyte imbalances you're most likely to see in renal failure are an increase in potassium, an increase in phosphorus, and a decrease in calcium. Okay, let me explain to you the logic behind this. So you know that there is potassium and phosphorus in the food that you eat, right? So if you're taking in potassium and phosphorus in the food you eat every day, you have to get rid of it somehow, right? Otherwise, the levels of potassium and phosphorus in your body are going to build up and you're going to have too much, okay? The normal way to get rid of potassium and phosphorus from your body is in your urine. So if you're in renal failure and you're not making urine, what's going to happen to the level of potassium and phosphorus in your blood? It's going to go up, right? So, why do we care? Okay, well, you already know why we care if your potassium goes up, right? Because you know that potassium is very important in the ability to generate action potentials, and you know your muscles use action potentials to function, and you know the most important muscle in your body is your heart, right? And so our highest priority concern with the potassium imbalance in renal failure is heart function, right? This person might start having cardiac dysrhythmias, and the cardiac output might drop. They might go into heart failure. They might even go into shock, okay? So that's a pretty big priority. Okay, what about phosphorus? Well, the primary reason why we're worried about having too much phosphorus is because you remember that phosphorus and calcium have this sort of inverse relationship, right? When one goes up, the other goes down. So the real reason why we're worried about having too much phosphorus is because it's going to make your calcium levels drop. So part of the reason why the calcium is low in renal failure is because the phosphorus is high, and that inverse relationship is driving the calcium levels down. But there's another reason why the calcium levels are low in renal failure. Do you see it on this list? It's because, remember, you need vitamin D in order to absorb calcium out of the food that you eat. And you remember that part of the kidney's job is to help the liver activate vitamin D. So if your kidneys are not doing that, you're not going to have vitamin D, which means you're not going to be able to absorb the calcium out of your food. And so the calcium levels are going to be low, right? So calcium is low both because the phosphorus is high and because we can't absorb it from our food because there's not enough vitamin D. Now maybe you're thinking, we said that potassium and phosphorus go up because there's potassium and phosphorus in our food and, we can't get rid of it in the urine. There's calcium in the food that I eat too, so why does the calcium go down instead of up? Okay, so here's the key. Remember we said that you need vitamin D in order to absorb the calcium from the food that you eat. You do not need vitamin D to absorb potassium or phosphorus. So even if there's not vitamin D, you're going to absorb the potassium and the phosphorus from the food that you eat, and the levels are going to build up unless you can get rid of them in the urine. With the calcium, because we don't have that activated vitamin D, even though there's calcium in the food we eat, we don't absorb it into our blood. It just stays in our GI tract and goes out with the poop. So that's the reason why the calcium levels don't go up the same way that potassium and phosphorus do. Even though there's calcium in your food, you don't absorb it because you don't have the vitamin D. Does that make sense? Now, interestingly enough, even though renal failure makes the calcium levels drop, we don't see those signs of hypocalcemia we talked about last class period. Remember we said hypocalcemia increases membrane excitability, and so people should be having tetany and dizziness and paresthesias and all those kinds of things. We actually don't see that in renal failure. And the reason for that is this. When the calcium levels start to drop, the parathyroid says, ooh, my calcium levels are low. I should make more parathyroid hormone so I can raise my blood calcium levels back up to normal. Now, what parathyroid hormone does is it looks for any way that it can bring the blood calcium levels up. And if it needs to take calcium out of your bones and put it into the blood in order to do it, it will. Okay, so in renal failure, when the calcium levels drop, the parathyroid makes more parathyroid hormone. Parathyroid hormone is going to take calcium out of your bones, put it into the blood, so that you don't have those symptoms of hypocalcemia. You don't have those cats of hypocalcemia. But what do you have instead? You have weak bones, right? You have osteoporotic bones. We call that renal osteodystrophy, or CKD mineral bone disorder. Okay, so if you look at this x-ray, do you see those dark areas that the arrows are pointing at? That's where the bone has been weakened, okay? Because on an x-ray, the solid things show up white and air shows up as black, right? So do you see where there are weak areas in the bone now because the parathyroid kind of the hormone stole the calcium from those bones to prevent the symptoms of hypocalcemia. All right. So I've just sort of summarized what we just talked about in this slide. So if you're the kind of person that takes it in better if you see it in writing, there it is. Okay, one thing that I forgot to mention when I talked about the renal osteodystrophy and the weak bones is because the bones are weak like that, we do see a lot of pathological fractures. And pathological fractures are actually bones that fracture with very little force. Okay, I mean, your bones are usually pretty strong, and you can, fall down and hit your arms and legs on things, and usually your bones don't break. A pathological fracture is a fracture that occurs with very little pressure because the bones are weak. A great example of a pathological fracture is a patient that I'm thinking of that one of my students worked with several years ago, her bones were so weak that when the nurses tried to boost her up in bed, you know how people, when you raise the head of their bed and they kind of slide down, and so we usually lower the head of the bed and we scoot them back up in bed. They kind of tried to boost her up in bed by, pulling her up under her arms, and they actually broke her clavicle when they did that because her bones were so weak. Now, we do that with patients all the time, and their bones don't break because they don't have that osteoporosis. So pathological fractures can happen. All right, your kidneys are also supposed to regulate acid-base balance. So if your kidneys fail, do you think you're going to go into acidosis or alkalosis? Actually, it's acidosis, right? Because if you remember what we talked about last class period, we said your cells are always making acids as a result of metabolism, and you only have two ways to get rid of all that acid, right? Your lungs and your kidneys. Now remember, your lungs can only get rid of carbonic acid because that's the only acid that's volatile. You can vaporize it and you can exhale it. All the other acids have to be excreted by the kidneys because they can't be turned into a gas, okay? So if your kidneys are failing, they are not making urine, they can't get rid of those acids in your urine, are you going to go into acidosis or alkalosis? Acidosis, right? Now, sometimes students get confused and they're like, well, the kidney gets rid of both acids and bases. So why wouldn't they have alkalosis just as easily as acidosis? Okay, so here's the reason, right? Remember we said that your cells are always making acids as a result of metabolism. When you make ATP, one of the byproducts is acid, right? So your cells are always making acids. Your cells are not always making base, right? So if your kidneys fail and you can't get rid of either acids or bases, which do you think is going to build up first? The acids, right? So the patient goes into metabolic acidosis. All right. Another problem that renal failure patients might have is anemia. Okay, can you figure out why? Because remember, the kidney makes erythropoietin, right? If your kidneys fail, it's not going to make erythropoietin. There's nothing to tell your bone marrow to make more red blood cells. And so the patient's going to become anemic. Does that make sense? All right. So remember we said that these symptoms actually can happen in either acute or chronic renal failure. But there are three of these things that we talked about that are much more likely to happen in chronic renal failure than acute. Those three things are the anemia, okay, because, you have to, in order to become anemic, you have to wait till a lot of the red blood cells that you currently have get old and get eliminated from your body. And then if your body's not replacing them, then you become anemic, right? So usually acute renal failure resolves before that happens. Remember, the lifespan of a red blood cell is about 3 months, right? And so hopefully your acute renal failure patient recovers before that time, and so the anemia is much more likely in chronic kidney disease. The second thing is the uremic frost, okay? The body has to get really desperate before it starts to eliminate waste in the sweat, right? And so that's usually not going to happen until the renal failure has been of longer standing. Okay, so that also is more likely in chronic kidney disease and in acute kidney injury. The last thing that's more common in chronic kidney disease is the renal osteodystrophy, because, it takes a while before your bones become that weak. Right? Your calcium levels might start to get low, your parathyroid might start to make some parathyroid hormone, but it's going to take time before the parathyroid hormone actually takes the calcium out of the bones and makes the bones weak. So the renal osteodystrophy is the other thing that is much, much more common in chronic kidney disease. Does that make sense? As far as interventions go, That's going to depend on whether it's an acute kidney injury or a chronic kidney disease. If it's an acute kidney injury, we're going to want to try and figure out what caused that acute injury and try and get rid of that cause. And then we're going to treat the symptoms while we give the kidney time to recover. So, for example, if we decide that the acute kidney injury was caused by giving the patient a nephrotoxic antibiotic, we're going to stop the antibiotic and then treat the symptoms while we wait for the kidney to recover. And by treating the symptoms, I mean we're going to try and control the blood pressure. We're going to try and correct the fluid and electrolyte imbalances, those kinds of things. And hopefully, given time, the kidney will be able to recover and be able to resume all of its functions. If it's a chronic kidney disease, however, the damage done to the kidney may not be reversible. Okay, now we're still going to try and identify what the cause was and try and fix that cause if we can, because we would like to slow down the progression of that chronic failure, right? We don't want to rush to the end stage, right? We want to slow that progress as much as possible. So if we find that it was chronic hypertension that started damaging the little vessels in the nephrons, then, we're going to try and control that blood pressure, okay? But we may not be able to reverse the damage to the kidneys. So we are basically stuck with treating the symptoms, trying to slow the progression of the disease, and if it does get to the end stages, then we need to start thinking about either dialysis or probably a kidney transplant. Okay, so by treating the symptoms, we're talking about, controlling the hypertension, maybe giving synthetic erythropoietin so the patient isn't anemic anymore. We might be giving calcium and vitamin D supplements so they don't get the renal osteodystrophy. We might put them on a renal diet, okay, because that could help minimize some of the symptoms. So here's what a renal diet might look like. And if you look at all the elements, it does make sense. Low sodium because you don't want to retain any more fluid. You're already fluid overloaded. Low potassium and phosphorus because your blood potassium and phosphorus levels are going to be high. Low protein, right? Because urea is what you get when you break down protein, and we don't want the urea levels to go any higher because that's going to make the uremia worse. So low protein, but we also have to make it high carb, because if we're going to do low protein, and we really don't like putting people on high fat diets because that's not heart healthy, you got to give them something to eat, because if you don't give them some source of calories, they're going to start breaking down their own body protein, and that makes urea too, right? So we got to have enough carbs so that they don't break down their own body protein. And then fluid restriction, okay? So this is actually quite a difficult diet to follow, but you can understand why there's the need for it, right? All right, so that's it for today. If you have questions, make sure you submit those. We will talk about them more in class. All right, I'll see you then.